Hello, my name is Cindy Miles, and I'd like to talk to you about apnea of prematurity and the treatment of it with caffeine. Our objectives will be, by the end of this lesson, to identify apnea of prematurity, apply that knowledge, and create a plan of care on an infant with apnea of prematurity, and to assess a premature infant needing or on caffeine and formulate any interventions that should be needed. Excuse me. So how many of you have had at least one cup of coffee today? Raise your hands. How many of you have had more than one? Raise your hands. Very good. So, tell me some reasons why you like to drink coffee. Keeps you awake, more alert, because it tastes good. As you can see, I really need my coffee. So let's open this PowerPoint and talk about apnea of prematurity. Apnea of prematurity is periodic pauses in a respiratory rate greater than 20 seconds with potentially cyanosis, pallor, hypotonia, or bradycardia. It results from an immaturity of the reflex pathway initiated by an increased CO2 and a decrease in oxygen. Apnea of prematurity potentially can significantly increase as gestational age decreases, and it can also result from other primary conditions such as IVH, intraventricular hemorrhage, infection, GER or gastroesophageal reflux, anemia, prenatal drugs or neonatal medications, temperature instability, and the list goes on. So if the infant is sick, there is a possibility that they are going to show more signs. Apnea impacts the brain neurons, leading to poor neurodevelopment. And the most important nursing key in this is documentation. You need to document that apnea and the interventions and how long it's lasted. So let's look at this next slide. This is a video of an infant having apnea of prematurity. And as you can see, as the video loads, you can see that the infant is actually apneic as you start to watch this video. There is no respirations going on. You don't see any kind of movement in the chest at all. And then the brain kicks in and the infant takes several breaths. And this cycle goes a couple times in this video. So the pharmacological treatment of apnea of prematurity is caffeine. That is the primary drug of choice to treat episodes of apnea and bradycardia. It has been used for treatment for over 40 years and has been shown to decrease the frequency of apnea and decrease the rate of BPD and decrease the rate of death. Also, it affects rates of CP and ROP, which is the premature retinopathy in the eyes. Caffeine is a very inexpensive drug. It has a very low cost to it. And its mechanism of action is that the body, so to start with, the body breaks down adenosine triphosphate for energy. That's how the cells work. and the result that's left over is adenosine. Adenosine binds with adenosine receptors, creating sleepiness. And caffeine comes in and binds with those adenosine receptors, preventing the sleepiness and stimulating the cardiac function, increasing the heart rate. Caffeine is given either IV or PO, and it is always given with a loading dose of 20 to 40 milligrams per kilo, PO or IV, and then there is a maintenance that's given. 5 to 20 milligrams per kilo every 24 hours, PO or IV. It is usually given during the day, ideally during the morning, so that the baby is not awake and alert and potentially irritable during the night. And it's administered, the IV is administered over 15 to 30 minutes to avoid cardiac dysrhythmias. And some hospitals and NICUs test levels for toxicity. Some do not. Toxicity is considered 40 to 50 micrograms per ml, above 40 to 50 micrograms per ml. So nursing considerations. You want to monitor the infant closely for apnea bradycardia episodes and document, like I was saying earlier. That is one of the biggest actions needed for treatment for these infants, is the documentation of apneic episodes. And the other thing is caffeine, if given in large doses, can be considered a possible risk for necrotizing enterocolitis. So documentation and assessment of the abdomen, the girth, the color, any signs and symptoms that are related to neck. Also, you're assessing for risks of IVH, intraventricular hemorrhage. And you're assessing for possible jitteriness or any cardiac arrhythmias such as SVT. So that is the end of my PowerPoint. Now I'm going to hand out papers that have scenarios on them. There are 2 specific scenarios listed in this paper, and I want you to divide into 2 groups, and you're going to go through these scenarios and have a discussion on what would you do to handle the case situation. And I'm going to give you approximately 10 minutes to discuss each scenario. But let's first read through these scenarios and talk about them and make sure you understand. So the first scenario, the patient is a newly admitted baby, female, gestational age is 30 weeks, mom had PIH, there was ruptured membranes for 15 hours prior to delivery. The infant's APGARs were 7 and 8. She currently is 14 hours old and she weighs 1,237 grams. She was admitted to the NICU on CPAP with a PEEP of 4 at 21% on FiO2. She has been to Kipnick with mild retractions, no other signs of distress. And the nurse that reports to you reports 2 episodes of apnea bradycardia with desaturation near the end of her shift. The heart rate had dipped to 80 with the apnea of greater than 20 seconds and a desat that went to 76, lasting approximately 45 seconds. She was documented as being dusky, mild stim. The other one was a heart rate of 82 with apnea greater than 20 seconds, desat to 78. It lasted approximately 30 seconds, modeled with mild stim. She has a PIV in place and has D10 IV fluid running. She is on an Omnibad with skin temp of 36 and her temperature has been stable. In the first 3 hours of your shift, she's had 3 more episodes of apnea. And she has had no other changes in her assessment. So what would you do? The second scenario I'm going to let you read on your own. If you guys would just kindly give yourselves a few minutes to have a discussion and decide. Thank you for listening to my presentation.